Hi everyone, welcome to today's session. I'm just going to quickly go ahead and share the screen and show you guys the startup presentation, and we can jump right into Dr. Nnaemeke's presentation. Thank you so much for being here.
Right. Thank you guys for having me. Good evening. How's everyone doing today?
Good.
Good.
Awesome.
Good, thank you.
So I figured the best way to engage with you guys, let me do a slight introduction of myself. Am I sharing my screen, or is this a screen as?
We just start off with like a really quick 5-minute like presentation for all of these, and then we can like quickly go to yours as well. It shouldn't take too long. Awesome. Thank you. Sorry about that. Hi, everyone. Thank you for joining Pre-Health Shadowing. We're an international student-led, women-led, minority-led nonprofit for medical advancements. We have closed captions, and you may actually be able to see the words under here as I'm speaking. If you have more ideas about how we can be more accessible, you can go ahead and email us at info@prehealthshadowing.com. Save us as a contact to keep us out of your spam, and join our email list so you never have to miss on our amazing sessions. And if you would like to stay in the loop, you can follow us on Instagram and TikTok. It's the same it's at Pre-Health Shadowing. And since we host from students all around the world, you can go ahead and put in the chat where you're currently calling from. I'm from California. And if you're interested in being part of Pre-Health Shadowing, we are always accepting student volunteers, and we're currently looking for team members. And it looks great on your resume, and it's such an amazing opportunity to be here. So here are some of the leadership roles that we have available at PHS right now. You could be part of the IT department and so many more. This is the link. You could also go on our website and go to the volunteering section and fill out this short little application, and we'll get back to you when we can. And if you're a high school student, you can also join our high school student training program, which offers leadership and healthcare education for pre-college learners. And if you're looking to get published, which also looks really good, you can go ahead and submit your articles to us. Now, since we are a nonprofit organization, we do solely thrive off of our volunteers, our team members, and the donations that we receive, as well as the kindness of people like Dr. Nweke, who are willing to do presentations for us. So if you have the time, you can go ahead and scan this QR code. It'll be great. Thank you so much. And make sure to type your questions in the chat. Our co-host will answer them we'll ask them during the Q&A. And take good notes, because there is a post-shadowing assessment that you can take, and you need to earn at least a 7 out of 10 in order to get your certificate. And please have your cameras on, because this creates the best, I guess, closest experience you can to a shadowing session. And we're all kind of like, you know, we don't know anybody, no one's going to judge you. It's great overall. And without further ado, I'll go ahead and pass it on to Dr. Nweke. Thank you so much for being here.
Thank you once again for having me. Let me just do a quick introduction. My name is Nnaemeka Nweke. Most of my friends that call me Anthony by my middle name. Born in Nigeria, I came to the United States in 1998. Grew up in Dallas, Texas. I finished middle school, high school in Dallas, then went off to University of Houston, in Houston to do undergrad, where I got my biology and I minored in health. Then I got my medical degree from St. George's University in Grenada. As you can see, I'm wearing the sweatshirt currently right now. And then currently I'm doing my residency in physical medicine rehab at Baylor College of Medicine here in Houston. I'm a third year resident currently as well. Applying for fellowship for pain management. So that's where I'm at right now. So for those of you guys that are everyone here is pre-med, correct? So yeah, so you guys are in a good place, a good, fresh place in your career, in your future, as you guys are formulating your goals, trying to, knock at the doors of opportunities, get exposure and things like that. You guys are doing well by having such a, event like this where you can learn. So I thought that I'm going to share with you guys a PowerPoint presentation that I did for my colleagues here. I felt that this has a huge teaching point and something that you guys could benefit from, even though you're not at this particular level, to be able to understand some of the stuff I would express. But the focus of this presentation is is more so having a mindset, right? Because there's a mindset that shifts as you go from a pre-med student to a medical student to now becoming a physician, and then taking on larger roles. When you're when you're pre-med, you're wide-eyed. You don't really know anything. You're faced with a lot of doubt. You're faced with a lot of uncertainty. But at the same time, you guys are super excited, which is very, very encouraging. As a med student, you've crossed the bridge. You've gotten into medical school. You start learning the material and things like that, and you start to feel like, okay, I'm passing exams. I'm getting smarter. I'm knowing so much, and your years as a medical student is so vital because that's the smartest you can ever be, right? You may think that the doctors now are like, oh, super smart, but when you have those basic knowledge and you learn all those intricacies and stuff like that, those are so important. Not that it's not important later on. It continues to be important, but the thinking style is different, right? You guys are seeing everything. Now, when you're a physician, you kind of like, you still think wide, but you have had so much experience that you know what to do. You don't blur about all these things before you get to it. Sometimes when you don't know something, you do need to kind of pull up a wide range of differential. So the reason why I'm talking this way is because there's a level that a lot of us get to that we tend to forget where we started, right? There's a level of empathy some people develop along the way, and there's not that they're not having empathy anymore, but there's just certain things you see in a clinical setting or in practice that can leave you jaded or leave you very judgmental, or you develop certain biases. Biases in medicine helps us a lot. There's biases that we use. You see somebody come in from a particular ethnicity, and you say, oh, they're likely to have this situation. When something manifests, you think about those situations, you bring that forward because you're like, okay, that person from this population is easy to diagnose. Example, if you're Jewish and you're concerned about your offspring having developmental delay or anything like that, then you have to think about all the things that cause developmental delay from the Jewish community that are specific to the gene. That's not a bad bias. That's just a genetic disposition that they may have. So, but oftentimes there's also biases that we formulate that could be bad, right? Sometimes when somebody comes in and they present a certain type of way, whether they're Black, white, Asian, they present a certain type of way, and you start to assume that this person is looking for this versus they're actually trying to get some help, but you assume that they're presented because of a secondary gain. So what the presentation I want to share with you guys is, it's titled, I'm going to share my screen now. So it's titled, When It Smells Funny, Be Suspicious. Ignore the date. As you see, I just did this presentation. So this is a morbidity mortality presentation. So in medicine, we always do like a morbidity mortality case and things like that. First of all, I want to ask a question. So this is being recorded, right? Would it be public?
Yes.
Okay, it's okay. I'm just not going to mention certain specifics because this is usually these are confidential presentations. There's nothing in my presentation that's going to have any patient information first and foremost, but the way I'll talk about it, I will not utilize because you guys don't know the individuals here or the patient in general. So I'll just kind of focus more on what you guys can digest and skip over the things that are not really that crucial, but still focused on the point. So the title here is When It Smells Funny, Be Suspicious. So quick outline of how this is gonna go. I'm gonna present the case. I'm gonna express to you guys about the outpatient visit course that we're gonna look at. We'll have a brief discussion, and then I'm gonna highlight again the teaching point. So here, so this is a 58-year-old female. So we have a 58-year-old female that presents to an outpatient COVID clinic. So it's just, I hope these days we're starting to have more COVID outpatient clinics because people after their acute COVID period have been noticeably having more symptoms or prolonged symptoms. So now, because of the compilation of those symptoms, they're categorized as having long COVID, right? So simply long COVID is a thing. So anyway, just capture this. This patient presents in such a setting, the same type of clinic. So the patient that presents, she's cachectic appearing, cachectic meaning she's lost a lot of weight. Certain features are more prominent, bony promise, and just basically it's showing somebody who has lost a lot of weight. And the lady presented in a hysterical way. She was accompanied by her husband, who was a surgeon, appearing in his scrubs. And highlighted, she didn't have any clear history about her complaint, right? So basically, she appeared as if she was drug seeking, right? And what was concerning about that is because she was already taking tramadol from a family member for her pain complaint. So her complaint was she was having diffuse musculoskeletal pain, and which later on was the primary focus of her pain was at the right lower extremity, where she was the spinal level that she was noted her pain resembled the right lower extremity. So at the L4, 5 of the L spine, and she was having numbness in that distribution. That's what the patient pointed out that she was most painful. So just kind of backing up again, she was complaining of pain. At some point, she was able to say, okay, I'm more painful at this region. I'm having more symptoms at this region. Past medical history, significant for asthma, chickenpox, colonic polyp, GERD, scoliosis, smokes tobacco, and has genital herpes. This patient's home medication is valacyclovir, tramadol, prednisone, metocarbamol. These meds, for those of you that may not be familiar, this is valacyclovir is a medication to treat genital herpes. Tramadol is a pain medication. Prednisone is a medication that she's on for her pain. Metocarbamol is a muscle relaxant to kind of treat her pain as well. Family history for this patient was non-contributory. Socially, she's a former smoker, quit 2012. She smoked to de-stress. She drinks alcohol 1 to 6 drinks per week. So question, so basically when this patient walks in, the question I pose here is, why are you here? So that's the question, that the attendant at the time was asking himself. So here I asked the question, how did we arrive at this particular visit? This is me, right before I started medical school. This is my nephew in the bottom right over here, pulling up on his first birthday. He had a more remote control vehicle, could pull it into his party. So anyway, the question, how did we arrive at this particular visit? So let's walk it back a little bit. All right. So a few months ago, this patient was seen in November 2021. She was seen by a family medicine doctor after receiving COVID vaccine for concern of for illness and vomit and worsening gastritis, which is stomach, stomach inflammation, essentially. And the family medicine doctor saw her, and basically, didn't really do anything. She was, that was the situation, and that which resolved. Shortly after that visit, December 2021, she caught COVID. So she already had COVID vaccine before, and she got COVID. And then beginning of this year, she was following a family medicine doctor some more on a telemedicine visit because she was noticeably having cough, congestion, and body ache. And these were the symptoms that she was presenting because of the COVID that she caught. Subsequently, in the same month, the family medicine doctor saw her again. At this time, her COVID symptoms had resolved, but she began to complain of back pain. And the back pain started in the upper back, and then started to have neck pain as well, and then noticed some low back pain. At this time, she was taking a leave and tramadol from a family member. So, the reason why I highlight the tramadol from a family member, oftentimes, what you guys will learn is, these are alarm signs, right? Certain medications like tramadol that you prescribe for a particular patient, um, people will tend to use this, give others their medication. They're not thinking anything negative about it. Some people may have negative intentions. Some people, that's just what they have at their disposal because they have pain meds and they didn't finish it. So the fact that she's taking a tramadol from a family member, it kind of brings about some, concern. If I'm looking at them like, who gave you the tramadol, without having any other understanding of where she's coming from. Already kind of gave the background that her husband is a surgeon, so he could possibly have, said, "Hey, I think you could take this." I don't know that. I'm not even thinking about that. I'm thinking about this when she comes in. So that will already create some type of concern in my mind, and so you can imagine if what the physician who saw her was probably thinking. The month after that, the family medicine doctor sees her again. At this time, she continued to have back pain, but she notes that it improves with walking. This time, she was able to classify her pain, which she says was a 2 out of 10 low back, bilateral pain that she was having. She at this time she didn't endorse any numbness or no urinary bowel issues. So the reason why this is important, just kind of have a teaching point while I'm going through this, is for those of you guys that are familiar. If you're not familiar, on your spinal cord, essentially you have spinal nerves, and of course spinal nerves, they're at their certain levels, they come out and they supply various regions in the body. And while we always want, ask these certain questions, especially about urinary and bowel issues, is because when you start to have urinary and bowel issues, that tells you the extent of your spinal injury. That's an alarming sign. That's something that's super concerning. The numbness and tingling are signs of radicular symptoms, meaning that you're having low back pain, but now if you have numbness, and it's just really affecting those nerves that come about. You could have low back pain that's focal, what we call actual low back pain, or facet medial back pain, which is the facet joints right there, but non-radiating, right? So asking these questions when a patient comes in about back pain is important to kind of delineate the extent where you're going, and it kind of helps guide your treatment plan. So she's taking ibuprofen, Flexeril. Flexeril is another muscle relaxant, and prednisone. You give prednisone a lot of times in acute back pain to calm down inflammation for 5 to 7 days. So they gave her this for 5 days, which she took. The month after this, she sends an email requesting physical therapy for her back pain. And at that time, thoughts were beginning to generate by the primary care physician that her symptoms may be now due to long COVID, right? Because they've been having consecutive visits. She had COVID. So now I was like, okay, how do I help her? So later on that month in March, the family medicine doctor noticed that the patient was continuously declining, right? And she was having muscle spasm, body aches, joint pain. She presents with multiple joints that was presented at multiple joints throughout the body. She had multiple tender points. So at that time, consult was placed for her to be seen at a COVID clinic, and as well for physical medicine rehab to assess her for needs of therapy and treatments and potentially to increase her function. So let's pause for a second. I'm going to express something real quick. So at this point, she has this diagnosis of post-COVID with manifesting with chronic decreased mobility and endurance. Something happened along this time period. At some point, the family medicine doctor ordered some labs, just because of, just to do due diligence. She ordered labs, given the fact that she had infection already, but she ordered labs that had some significance. In February, these labs came about to show that something we call CRP, which is critical reactive, which is C-reactive protein, and then ESR, which is a sentiment, which tests sentiment or rate, basically kind of telling us how much infection is going on. Basically, just kind of tells you, oh, this number is high. There's a lot of inflammation going on. CRP is important because it tells you these are acute phase reactants that tell you how active an infection is. So these numbers are very alarming and high. So at some point, the doctor emailed her and was like, hey, I think you need to go to the emergency room and get this looked at. But when I was looking at this case, it seemed like the patient did not respond to the message till like later on in April. So meaning that she probably didn't take care of this or get this looked at further. So we move forward. So critical points here. This patient now is in a clinic that she was told to go to. She was seen in April of this year, and at that time, her symptoms were still consistent with diffuse musculoskeletal pain, having primary focus to the right lower extremity at the lumbar level of L4-5. And then at this point, she started having numbness in that distribution. And so I say here that she began having all this after she was diagnosed with COVID. And as well as her primary focus being right lower extremity, she also had upper and lower extremity concerns. But at this time, the left side had calmed down as a lot more, but her pain continued to be quite severe in the region that she said for us to primary focus on. And minimum, even the slightest movement will cause her to be in severe pain. But overall, she was still walking. She was walking with an upright walker, and was needing considerable assistance to move around. So she's at this point, she's been through a lot of workup. And I highlight here that she's with her husband, who's a surgeon, and also doing this visit The physician that was seeing her noted that she had the CRP that was 4 times the normal limit. But overall, patient, she denied fever, nausea, and chills. Why that's important is that, these are symptoms that sometimes when you are having inflammation at this extent, usually there's something that somebody can tell you that's consistent with inflammation. And usually you have fever, but she didn't have any fever. She didn't have any nausea or chills. Um, she underwent an imaging, but at this particular visit, there wasn't any report that was available for the physician to kind of like get a picture. But let's go back some more again. Remember when she first presented, she came up with she looked, it was a bit sketch, right? Um, just kind of giving a frame of mind from my conversation with the physician that saw her, he was like, hey, literally, I don't know why she's really here. It doesn't sound, and it wasn't really consistent. And that there was a lot of doubts going forward. But just like what he's supposed to do, he did. He was seeing a patient, doing due diligence. He attempted to do physical exam on her just to kind of take what she says subjectively and see if there's any objective finding. Um, but the exam was super limited because she was such in significant pain that even the lightest touch, caused her to feel irritated. So he didn't do it much or any manipulation to bring anything in. It was more so what she said and what he just kind of identified, which were the right low back, right low extremity pain at the L45 distribution with some numbness. So once he concluded all of this, now the plan was he decided, I'm gonna just go ahead and ensure that there's no lumbar radicular symptoms going on or issues. Let me order an MRI lumbar spine. So that is the highlight here, that he went ahead and ordered MRI, and I'm gonna talk to you guys about when ordering something. The way things are set up, you can't just order anything, right? A lot of times you have to justify why you're ordering what you're ordering. A lot of times insurance, depending on the insurance that a patient may have, you need to have a medical necessity before they do such a thing, before insurance can even cover it. And a lot of times people only get those images done because insurance doesn't cover, they don't get approved to go through because they have to prove it. So a lot of times it's proven on your physical exam if there are findings that you can justify and say medically necessary, they need to get this. Usually most cases you order x-ray of the back. Nobody's going to challenge you for why you order an x-ray. X-ray, you can order x-ray. And if you have a suspicion for something, go order x-ray. But when it comes to higher magnified imaging like MRI, it's expected that you have some justification. Based on what was corralled at this visit, I don't think there was sufficient justification, but the physician did due diligence, right? Given what he's accustomed to seeing and the fact that, it just looked like this was probably going to give us more of a clear picture. Most of the times, like I said, this wouldn't be a lot of people's first hunch. And a lot of times you may think you may have to hunch, but the patient may not even get the MRI done because some of them, the insurance want more. You got to do a peer-to-peer. A lot of times you got to do a peer-to-peer. You got to prove something. But just to kind of highlight, this particular clinic location have certain patients that they see who have pretty good insurances, and thus certain things can be ordered and relatively can be done quickly. So moving forward, so I highlight here that what he says that with that said, we will ensure that there's no lumbar radicular source of the primary focus today via MRI L spine. So when I was doing this, I just asked my peers, which I'm not going to ask you guys this question, but I asked my peers, how often they would jump to MRI when there's no major neurological signs. Had everybody, express their feedback and what they would do. Some said that they would have thought it as well. Some said they may not have done that either. maybe something else. So, and it was like a muddy zone, because what we practically see is if we have signs that really truly says MRI, we go do that. But he made the clinical decision to order MRI, given that he didn't have enough to even rule justification to do the MRI. But at least I'm speaking on what he was saying to me. If you saying that you were concerned that, oh, the way she looked, I think there could be concern for cancer. But like I said, if there's not any significant alarming sign like the bladder bowel issue or numbness like that, which she didn't mention, but the fact that he wasn't even able to do a physical exam on her, you know, I would have thought about doing something less than MRI, to be honest. I wouldn't have thought about MRI. And so moving forward, so I asked this question, and I guess I can ask this to all of you guys. I don't know if people can speak on this Zoom multiple at the same time, but the question is, what do you guys guess might be the finding on the MRI, given the symptoms and lab findings? I'm asking this, not expecting you guys to have a lot of answers. I don't know if you guys would know what to find in the MRI or what to identify, but if somebody can give me a response, that'll be at least good enough for this question.
You guys can go ahead and put that in the chat or raise your hand. Either one works.
So if they raise their hands, you just unmute them and they'll say something.
Everybody could actually unmute here, so don't be shy.
If you have
really,
something,
yeah,
I'll give y'all like
give it 30, a go.
Yeah. So what would you expect? What would you have expected on the MRI? With everything I've said so far, like what could you assume?
I would assume that there's something that corroborates what you were looking for, and I don't know what that would be or what to look for, but if that she's sensitive to the touch and all of these signs are kind of alluding to it, then I would presume that the MRI would give us more information about precisely what's going on, but I have no clue.
Okay, all right, I like that. So I will take that. We'll take that because I don't want to put you guys are pre-med, so I don't expect that you guys have a lot of like differentials to blurb out. But that's a great thought. That's exactly the reason of getting an MRI, just to kind of see if there's anything more focused that we can see. So here are the findings. So MRI comes out, first of all, just a backstory. I'm giving all the MRI findings from the cervical, thoracic, lumbar level. Let me walk this up in the true way that it happened. When you order an MRI, you basically order it section-wise. So because she only pointed out to the low back, the MRI order was focused on the lumbar area, which is the L, which is what we call L spine. So that's what the attendant initially ordered. So he ordered that, and it comes out that she has something we call, let me go back. She got something we call osteomyelitis. So osteomyelitis is essentially infection of the bone. So, and that the only way to see osteomyelitis is with MRI. If you get an X-ray, you may see like bony changes, but you will never see like osteomyelitis. You see something wrong with the bone, but you won't see osteomyelitis. You have to look at it you have to see it via MRI. So what happened was, the reason why she was able to get the cervical and thoracic done was her husband, being a surgeon, had a friend that's a radiologist. Unbeknownst to anyone, the radiologist that's a friend to the husband was the one reading these images. It wasn't like, oh, designated for him to read. It just happened and he was the one that read it. So given the name and given association, he saw the lumbar spine findings, has some suspicion at the levels above decided to go ahead and just get a cervical and thoracic image done. He bypassed notifying the primary physician who ordered this, but communicated this to the patient's husband, right? So when the attendant who ordered the lumbar spine finally got the report back for the lumbar spine, he was like, oh my gosh, this is what's going on. I need to call her or call the husband to say, hey, this is what's going on. I want to let you know. By the time he called, they're basically saying, oh, she's already in the hospital. We know, right? And here's what we also found. So she come to find out that she had osteomyelitis that had developed in the cervical region, mid-back, thoracic region, as well as a lumbar region. So I asked the question, so what now? Anyway, long story short, she underwent IR guided biopsy. With osteomyelitis, you have to be on prolonged antibiotic treatment. So she underwent that antibiotic treatment. She returns back to the physician who saw her in August of this year after completing the course of antibiotics. But she was still endorsing like some slight tingling in extremities and stuff like that. But for the most part, her functions were back. She wasn't having as much pain. She did lose some weight. She dropped weight from 160 to 120, but gained 10 pounds back. She was noted to have lost some inches to her height, likely a result of the intervertebral disc, loss of the disc consistency, leading to autofusion. So likely a result of the inflammation and the infection that was happening in the spine contributed to her having some kind of fusion occurring in the disc, bringing her height a little bit, lower. But that's where she was at in August, and the plan at the time was just to do serial imaging just to make sure that some of that, some of those things have improved. But once she's done with the antibiotics, then that treats the infection. So I think I'm going to skip over this part a little bit. I think I explained some of that along the way. I said, who ordered the cervical? So as you can see, the way this is presented, I presented this in a way where it was kind of blindsided for everybody, but the way I'm presenting to you guys, I'm kind of telling you the story and focus on getting to the teaching point. So like I said, the husband's, the surgeon, the friend who's a radiologist, was the one that saw these findings, bypassing the primary physician that ordered it, and then ultimately was helpful for the patient. But the highlight, though, is the turning point that I wanted to focus on, the teaching point mainly that I wanted to focus on, was the fact that the primary physician, even though he had doubts, a lot of times, depending on the patient population or depending on the location, and this is very important for everyone, but focus more on on pain management aspect. Sometimes when it comes to pain management, you have to be mindful of people you don't want to assume that somebody's not in pain. A lot of times when people are met, like, for example, a lot of women of color, when they go through birthing process or delivery, there's a lot of people, stories or their experiences, that feel like they're not properly managed for their pain because they're assuming that they could handle pain. But when they're in pain, somebody's assuming that they want something secondary gain as opposed to actually treating their pain. And you find many people who are, find some disparity along in the medical world in many, many ways. So what I wanted to focus on was how, when, realizing when you're becoming jaded in practice, but at the same time, whenever doubt kicks in, do more. Anytime you're like, oh, no, it can't be that, just do more. Anytime you're like, oh, no, try more. Like, do everything textbook wise. You want to cross all your T's and dot all your I's as much as possible. And just looking for a clinical answer. Look for a clinical reason, something reasonable to do. So which what he did, he said, hey, point out to me where you're having the most pain, as opposed to just saying, oh, you painful all over. And that doesn't seem to be consistent with anything. I don't know. It sounds inconsistent. He said, point to me where you're having the most pain. Say, you know what, I'm going to image that location just to see. And then rightfully, because he did, it opened up the doors for all of these things. He didn't, because nobody considered the upper back. Nobody considered the middle back. It was like, where are you most painful? And said, you know what, let me tackle that. And it comes out to be that something was growing at that level, then had someone who was a family friend, essentially, you know, turn it up a little bit more and go and seek out these other areas and find something. So imagine a scenario where this person does not have the financial wherewithal, complaining of such thing, don't have the insurance capability to have something executed so quickly, and ultimately don't have advocates around them that can kind of like cause somebody to sit upright. The surgeon being present with her probably influenced a lot of stuff in the clinical setting. And at the same time, the social environment that she's a part of also enhanced her abilities to get taken care of and for multiple eyes to be at her corner, as opposed to her presenting how she did and being counted out. So she had those things that assisted and ultimately changed the nature of her caretaking. So whenever she came back again in August, I'm here, you know, what's on here is her physical examination. So basically overall her strength was intact. Nothing was really alarming or negative on examination. And the plan was to perform serial MRIs over the next year, with the next one being later, you know, that month in August. And I'm sure she's currently getting serial MRIs just to keep her, to make sure that she's not having any more developing issues. So just to kind of emphasize on the conclusion, I'm gonna expand a little bit more. I'm getting to the end of this presentation, but we still have time to do some more things. So the focus here is that when something smells funny, be suspicious, right? Just the smelling of it being funny, just be suspicious. If you're concerned that somebody's drug seeking, rather than counting them out, say, you know what, I want to make sure that you're for sure, before I go ahead and give you anything, I want to do a urine drug screen, just to make sure that you're not already taking anything before. So that's one way to kind of support and protect your bias, a little bit, and make sure you're still doing it for a particular reason, because you want this patient to get. So you get a urine drug screen, and you see that the urine is clean, and you're like, okay. If there's anything that was suspicious, that removes that suspicion, and that gives you more confirmation to do a little bit more. And as a physician, you're a detective. If you sniff something, you kind of want to prove that. It's important to don't sniff and conclude. Have justification, have objective. If you rely on all subjective stuff, it may create a lot of untrue things. So by having objective things, objective findings, that rules things in. That's what we do, right? We don't do make believe. We basically find something, and then sometimes though, there are certain things that you use clinical reasoning to anticipate. Anticipating something is off experience. So a lot of times you can anticipate, but also make sure that you order the right things to kind of support your anticipation. You have to kind of cover yourself and protect yourself. So what I want to highlight, the reason why I did this M&M is because it covers both medical and social determinants. And when you look at these factors, there are people who are not benefiting from healthcare adequately because there's some flaws, and they may not have certain determinants at their to help them. And for example, in this patient, medically, she had the support, she had the connection. It just happened to work that way for her, that she had the connection, and that was what expedited the process. That the primary physician who ordered the MRI was basically trying to get, but something was a catalyst, along the way to help drive that to full fruition, in many ways. Socially, she had the insurance to support, her getting the MRI as quickly as she did, because like I said, sometimes when there's not enough information, you could order an MRI, but it might just prolong for some time before somebody gets approved for it to be done. It's not an immediate thing that can just go and do very quickly. Sometimes you have to get approved. But some settings, some critical settings, and the type of patients that they may see, it's not a thing for them to get approved once the peer-to-peer is done. So this patient was coming from a population that had those two arms at their use, and it worked out for her effectively. So I just want to kind of highlight that, as a healthcare provider, to stay on your toes, even if it's the last patient of the day. Sometimes we're trying to get out of there. You had a long day, you're tired, you're beat up, or something from outside of your, involving your life has penetrated to your day while you're in a hospital. And, it may affect your full throttleness in what you're about to do. And, I highlight that if all your senses, if all your initial senses are telling you that this might not be a thing, to always try. And when dealing with a patient's life, you have to always try, because if she was overlooked, if the physician that ordered the lumbar spine, she may have felt like, nobody believes that I'm truly in pain, and may have never had anybody find these things out. And it could have been worse for her. She could have developed something in her brain, given the fact that it's already in the spine. It could metastasize, it could spread, infection could spread through vessels and seed in the brain. That would have been more catastrophic for the patient. But ultimately, this was identified and she got treated with the antibiotics. But once again, I bring this up so that you guys can kind of armor yourself, because in the future you're going to be in a position, you're going to be in a role to advocate. Sometimes patients coming in, they may not be able to advocate for themselves like that, but you're going to be in a position to advocate. At the same time, you're going to be in a position to dictate what somebody's care is going to be. You're going to be in positions to make sure socially, dealing with the social workers, dealing with anybody, that once this patient is seen that outside of the hospital, that they have all the resources they need. You're going to see patients who don't have the resources. You're going to see some that have resources. And you're going to see the difference between the ones with resources get treated versus the ones that don't have great resources. Because the way things in medicine is just aligned is a lot of physicians are not as willing to work for populations that don't have coverage. If they don't have coverage, then they're paying mainly cash, and these people don't have that. So everything relies on insurance most of the time these days. And with that being said, some people don't have that insurance coverage that could be super helpful for them. So all of these things are important. And when you have certain situations in practice that now could decrease your desire to do something, when certain things are in place that are working in your favor, that helps you a little bit more, increases the, you know, the chance that you're gonna get what you're gonna be taken care of, right? Because all things are pointed into one decision helping you, as opposed to, the primary physician would have ordered this, but what if those other things didn't go in favor for the patient, and ultimately never really got the MRI done to maybe a month after? Talk less it being done and having someone in the review room saying, "Oh, I know this person. I think that they need further imaging." So this particular presentation captured that for me, and I thought that would be a great thing to teach my peers, continue to teach more people. I'm actually going to write up actual case report for this particular case, and pull in some more literature review on medical and social determinants, or anything that health determinants in general, just kind of like continue to preach this message to myself and to other physicians to just stay awake. What they say, stay woke. But anyway, so that's the conclusion of this case. If you guys have any questions, feel free. We can tackle those questions now.
We have about 7 minutes left, so you guys can go ahead and put your questions in the chat.
Well, the thing is, I'll answer as many questions as possible. I know I said
okay.
So
we'll just see where it goes. I actually have a question because it was on one of your slides regarding whether or not, like, I think you said if the patient's husband is a surgeon, does that affect their insurance or no?
Yes, I think what I meant. Let me go back to the question. I think what I said in that question, I said, let's see. I said, yeah, I was saying, could the extra coverage that was done by the physician, could that have been influenced by the patient's husband being a healthcare worker, a surgeon at that, like in the room, right? So she didn't come by herself. In that particular room, I felt like I put myself in the physician's shoes, that he would have sniffed it if there was something, right? So basically, the surgeon would have thought something because he took a Hippocratic oath. So he has to think. So because he was there, and his position in the field is a surgeon at one, just to kind of highlight that as well. We would say, "Oh, you're a surgeon, you have to be smart," right? Not to say that, oh, because you're not a surgeon, you're not smart. Every physician is smart, but just in general, we know that in order for some of these specialties, the way things are measured as you go, they're always looking at a board, exam scores or work put in, or expecting things are. So you like to say that a neurosurgeon, orthopedic surgeon, these individuals are intelligent. They're in a different division category in general overall, but every physician is intelligent. But I brought that in because it could have presented some type of intimidation or a need to not do something that is important. So I was wondering, did that influence the physician to even say, what, let me make sure I do everything. Comparatively, if she didn't walk in with a significant other that is in the health field, would that have made any difference as overall? So that was a question I posed to my colleagues.
Awesome, thank you. And we have a couple of questions actually in the chat. The first one being, what is ABX?
What is what?
ABX?
ADX?
ABX.
Oh, ABX, antibiotics.
Awesome. The next question we have is, could you talk a bit about what your daily life is like in PM and R? Thanks.
Okay, so physical medicine rehabilitation, it's a field that addresses overall function, right? Our goal is to improve your activities of daily function. And sometimes your activities can be affected by multiple things. And the focus is on in PM&R is we focus on a lot of musculoskeletal, right? And in order for your musculoskeletal system to function, you have to be intact neurologically. Not only you're intact neurologically, your neurological system overall is your brain, your spine, right? So in PM&R, there's a lot of brain injury that we deal with. There's a lot of spinal cord injury that we deal with. And then aside from all those big parts, you have peripheral issues that we also started musculoskeletal issues that come about with sports injuries or any injuries overall that can affect you or debilitate you. So the goal with physical medicine rehab is to help get you back to your daily living, right? And sometimes you may not look like what you used to have before, but if we see that you're in need of further assistance, we can always equip you with equipment to assist you with that. Equipment complemented by therapy to get you more improved. Example, a patient gets a spinal cord injury. The goal is to, get you functioning, moving your legs if you can, or moving about to try to do things that you once could before. And obviously everything's all goal focused. So you may not be able to utilize your bowel and bladder as you used to before, but now we train you given your situation. We teach you how to catheterize yourself to initiate peeing, just so that your bladder doesn't overfill without, and become this overly distended and, destroyed. We teach you how to time void. You may not feel the urge because you've lost that that sensation to feel an urge. So now you're taught how to categorize, to cath yourself, every 3 hours or every 4 hours, given what you're comfortable with. But we teach you that. So back to the question that I was asked. So currently right now as a resident, I'm rotating at different sites. I just concluded brain injury rotation and now I'm doing outpatient sports stuff. So general hours for resident is from 8 a.m. to about 5 p.m. And on day-to-day basis, the general is like every day, like every other thing. You see your patients in the morning, you look at them on a computer, you remember what the day before plan was, and you come into the next day expecting to find out something or seeing what the plan was and how they're developing towards that plan. In rehab medicine, a lot of stuff is just a journey, it's a slow process. There are some things that you're expecting to change the next day. So when you're looking at your patients in the morning and you're doing some checks right before you go and see them, you check all your labs, you check all your vitals, you check all your overnight stuff, you check to make sure that they're peeing and pooping okay, such and such other stuff, right? And then I will now go and I round and I see all patients. Sometimes while rounding, you may have other things pop up by nursing, by, that you kind of have to address. So you address those. And then once I'm done rounding, then usually now at this point, I try to start writing my notes. And while writing notes, you're just actively, doing whatever comes about. And oftentimes if you get time, You can go watch some of the therapy that they're undergoing just to see how they're progressing in those sessions, as opposed to being told how they did at that time. So you kind of want to get yourself as involved as possible. So I would do all of this stuff, and I would write on my notes to hopefully finish before I leave 5 o'clock. And sometimes while inpatient, you get admissions. So you get admissions, new patients coming in. So you got to have the knowledge to say, oh, okay, I'm doing this, but I have to prep this because patient could be coming in. So let's say in a situation where a patient is coming in at 3 p.m. and I'm still working on the current patient, then I would at some point prepare their orders prior for them coming in. So that when they come in, I just release the orders immediately so that they get situated. Rehab is different than inpatient medical services. Rehab, you actually go into another place as if you are going to be at home. So sometimes patients come from home, so their rehab, it stays is picked out. And then sometimes patients come from an acute care facility to inpatient rehab. Sometimes people have fresh injuries, they get fresh surgery, and they're supposed to be getting rehab, immediately post-op. So we do get those patients come in. Anyway, so when admissions come in, take care of those. If you're not on call after 5 o'clock, then you're off the clock, and then we go home. But oftentimes, responsibilities spill over. I have a tendency to still be working on stuff after the work hours at home. So I'm still working, and sometimes I'm probably still writing notes till late, depending on how busy the day was. You may not get a chance to do all your notes at the same time. It's at least do it efficiently, not just to do it rushed, because things change. So baseline, my work day is from 8 to 5, but honestly, work is usually from 8 to 10, to be honest. So sometimes 8 to 11 p.m., from 8 a.m. to 11 p.m.
Thank you. And the next question we have is saying, I came late, so I don't know if this was already covered, but I was wondering how your journey led you to St. George's University. I'm assuming you went there because of your hoodie.
Yeah, so I went to St. George's. I went to St. George's because I had some challenges getting into medical school from undergrad. I took the MCAT 4 times, applied 2 years in a row, didn't get into medical school. And I was on my way to take the MCAT the 5th time. At this time, I became open to schools in the Caribbean, and then I applied with what I had, and luckily, I was accepted at St. George's School of Medicine, and that's how I became an SGU student. But it wasn't easy getting to that point, and once I got into medical school, it hasn't been the easiest either. So I've just been jumping over one hoop after the other. Initially, my goal was to go into orthopedic surgery, right? But challenges were in front of me. I still kept that focus, even though it's super challenging to go to those type of specialties from a Caribbean school, but it gets done. I just had some challenges doing it. So I went on MASH for residency 2 years in a row. Along those time periods, I had to start exercising other options. And I came to know about physical medicine rehab a little like later on in medical school, and as a med student. And during the periods where I didn't manage is when I started to have more of the thought process to go into physical medicine rehab. And then ultimately find myself here after having gone through, a lot of work to get to this point.
Awesome. The next question we have after that is, How do you deal with patients that actually do not need medical help, but are pretending that they have medical issues because they want to take drugs that they don't actually need? Have you experienced this kind of case scenario?
Yeah, it's always there. And when you encounter patients like this, right? You still want to treat them, like I said, you still want to treat them like any other patient. You treat them like any other patient just to avoid doing anything that walk them into that corner or them walking you into a corner. Oftentimes, you may tell a patient, let me see how you do, let me see how you improve with this. You don't give them any meds, but you order like, physical therapy or something, or you can order other stuff that might, that given what you're thinking will be helpful to see if they actually go and do that. Right. If the patient say, oh, they want this, and you say, no, I don't think this is what you need right now. Maybe we can get you a lidocaine patch, or something, to see if that helps. And if the patient now shows you a reaction, that, oh, that's not what I want, that kind of start showing you that, there's something else that they're looking for. At that point, you kind of made your diagnosis of that, and you just but you don't put that in their face immediately. You have to kind of do something that makes sense. You have to use psychology, and a lot of times, to kind of see if you can give them something that is a placebo, to kind of help them overcome that thing that they're thinking about. Usually something like that will help. But if a patient realizes what you're trying to do and then now expresses, their distaste for your clinical decision, of course, that will really show you that, something is off. And then at that point, you can really close the door.
Awesome. Thank you so much. And the question after that we have is, was there anything you would do differently during your path to St. George's?
No, I wouldn't do anything different. I mean, often sometimes, you think back and you say, oh, maybe if I went to, American school, maybe I would have been an orthopedic surgeon, but I think the story is aligned how it's supposed to. Hence why I'm always in position to do things like this. So I wouldn't change it.
Awesome. And the question after that we have is, what pre-med classes did you take in college to get to med school?
So everyone has to take organic chemistry classes. You have to take all your biologies. You have to take all your physics. You have to take all your regular chemistries. I took some advanced biology classes like plant physiology, took endocrinology, took cell biology, biochemistry. But not only those core science classes, you want to take other stuff too that kind of engage you. I would recommend, I think I took some drama classes and stuff like that, for some philosophy classes and stuff like that. But if you're trying to fulfill, a particular degree, then you want to make sure you fulfill what that degree plan is. Going into medicine, specifically, but not everybody has to do a biology degree to go to medical school.
Awesome. And one moment, I'm just kind of scrolling through this. Does COVID-19 exacerbate inflammatory diseases in patients with pre-existing conditions? If so, how is that being monitored and cared for?
Does COVID-19 exacerbate? I mean, yeah, absolutely. Whatever is already ongoing in your body and you get COVID, there's likelihood that it could exacerbate that. At the same time, have its own, issue that it wants to deal with, that presents. If you already had a baseline lung issue and COVID-19 is a respiratory infection, that can exacerbate a patient with COPD that's already there. At the same time, COVID doing what it does. It is an inflammatory disease that causes disease through, inflammation throughout the body. Hence why you can have like bone achiness and all of that stuff. So if you already have inflammatory processes ongoing, yes, there's potential for COVID to exacerbate that.
Awesome. And after that, we have, one moment. You gave us info about the family friend of the woman's husband who was a radiologist and did some radiology on the lady. Why was that exactly relevant to the woman's diagnosis, especially since she was already in the hospital? He was essentially too late.
Say that again.
Yeah, of course. You gave us info about the family friend of the woman's husband who was a radiologist and did some radiology on the lady. Why was that exactly relevant to the woman's diagnosis, especially since she was already in the hospital?
She wasn't in a hospital. This was an outpatient setting. So the relevance of that was she wasn't in the hospital and he saw the film. As a radiologist, he read the film from outside. But the importance of that was this is something that somebody needs to be in the hospital to be treated for, right? So that relevance came about because if it was any other radiologist, I don't think that he would have ordered a cervical and thoracic because he's not related to that, the husband, and then, and because he's related to the husband, he's not related to her, but because it's a family or person that knows the husband, he had more of a reason to do more, right? If it was just any other radiologist that read it, had no affiliation, he may have stopped at that lumbar spine and probably didn't even think to send an alert to the physician. But obviously, finding like that is alert appropriate. So most people would say something, but it's the fact that he did these other stuff, which was beneficial. A lot of people may just leave it to that primary area without escalating to look at everything else. And he did that without even notifying the primary physician. So that's the level of significance in the whole case.
Thank you. We have some more questions in the chat. It says, what hospital is your residency program in, if you're comfortable sharing?
Well, I'm Baylor College of Medicine. We rotate at different hospitals within the Texas Medical Center. So if you want to know more about Baylor College of Medicine rotation, there's a website. But basically, in short, the Texas Medical Center is a hub. So we have clinical assignments at various locations, depending on what we're doing at the time. For example, for pediatric rotation, for peds rehabilitation, we will be at the Texas Children's Hospital because that's where those patients are. Obviously, you may see pediatric stuff in general rehab floors, areas that we see. But as far as training, we get bulk of our focus training in peds at the Texas Texas Children's Medical Center. And also we rotate at the Veterans Affairs Hospital, the VA, where, former people in service come, and those are the bulk of patients we see there, and such other various sites. The core of residency is to get you exposed at all these different areas and settings. And sometimes people continue diversifying themselves in a large pool. When they're done with residency, some people say they want to focus on a particular population to treat. And they go into a focus and say, I want to just treat pediatric patients, and that's what they want to do. So, but yeah, we here at Baylor College of Medicine, we have multiple sites that we rotate.
Thank you so much for answering that. To add on to that, someone else has asked, what were some contributing factors in your decision to go to medical school?
Well, for me, I wanted to go because I used to my drive was to one day potentially go to the NFL. I love football, play sports and stuff like that, but I tore my ACL. So after tearing my ACL and making the decision that, I want to use my abilities, my mind, and do more, and use my hands to do more. You know, all of that together pushed me to going into medical school.
Awesome. And next question we have is, what coping skills are physicians using during COVID-19 to avoid burnout?
I don't know of any specific coping just for COVID-19, but physician burnout, what we focus on, especially as a resident, is we always highlight wellness. So the programs do a great job trying to make sure that we do wellness activities, encouraging people to implement wellness. And that coping could be exercising, having activities together, or stopping a particular period of time to say, oh, let's do an activity together as a group. And all of that is essential to help cope. As an individual, you should also find some things that help you decompress. That helps reduce burnout.
And one of our last questions in the chat is gender distribution a factor to consider? I'm a guy interested in pediatrics, but people keep telling me that's a woman's job, or at least populated by women. How severe is gender distribution in pediatrics? I personally think it's irrelevant.
Say that again.
Yeah, sure. Is gender distribution a factor to consider? I'm a guy interested in pediatrics, but people keep telling me that's a woman's job, or at least populated by women. How severe is gender distribution in pediatrics?
I don't actually know how severe gender that is in pediatrics. But that's a good question. I think what my advice would be to look further into that, maybe type up the research on and see if you find some numbers, but I don't really know the specific answers for that specialty based on distribution. But I can see where that may have some more women than males in the field. But to me, I feel like there's a good balance though. But given the fact that I did rotations and I'm seeing more, and I'm seeing more, sorry about that.
No problem.
And I'm seeing more women in the field than males. It's probably consistent with what he's saying, but I would research the numbers just to be specific. I don't have a specific number for that distribution.
All right, this is our last question, and then I'm going to go ahead and share our wrap-up slide. So thank you all for being here. Our last question is, who would you recommend PM&R to?
Who would I recommend PM&R to? I recommend PM&R to everybody. Anybody interested in musculoskeletal field and things like that, I recommend that.
Awesome, thank you so much. I'm going to be sharing our screen real quickly. All right, so let's go ahead and reflect today. What brought you guys to this session? What are 3 major takeaways you got from this presentation? And what do you want to learn more about? You can go ahead and put that in the chat. And once again, if you would like some bit of recognition, you can go ahead and submit your thoughts on today's session to our website. This can be articles, reflections, reviews, and success stories. And we're always looking for student volunteers, and we're currently recruiting team members, so join. And if you can donate, we would highly appreciate it. We have our QR scan code here. We are a nonprofit, and we do depend a lot on our amazing volunteers, team members, as well as people like Dr. Nweke, who are willing to present with us. And now that we've come to the end of the session, make sure to take the quiz at the end of the session. It should be up by 7 p.m. PST, so maybe in around like 30 minutes or so. If it doesn't, please go ahead and email us. It's on our website. You can find it in the contact Sahasra, would you also mind putting the pre-health shadowing email in the chat so people can see it? Thank you so much. In order to get your certificate, you need to pass with a 70% or higher. And if you get a lower, do not be scared. You have 2 chances to receive the certificate. And if you miss any part of this session today, you can go ahead and visit our YouTube channel at Pre-Health Shadowing to watch any of our previous sessions or this one for free. Be sure to catch up on all our sessions every week by going on our website, following us on our social medias and such. Thank you all for being here. We hope to see you again. If you have any questions, feel free to stick around and ask the student team. Thank you.
All right, see you guys later. Thanks
Thank you
again
so
for having me.
much.
All righty.
Thank you so much. Yeah.
Thank you so much. Have a nice day.
All right, see you.